Thank you very much, Dato. Actually, it's a great privilege to be here today to speak to you all. So, for my first involvement, actually, with this support group, especially in relation to prostate cancer. I was actually told to talk initially on something else, and there was initially an overview of prostate cancer in Malaysia. And then the topic somewhat changed to new imaging modality, which something not I'm quite comfortable speaking about because it involves radiology. Nevertheless, we'll just try to present to you what are the new things. You may have some better ideas about things because you may have read things as well along the way, how we diagnose prostate cancer, what are the new things available, and so on. So I think prostate cancer is very central to the diagnosis of prostate. Imaging is very central to the diagnosis of prostate cancer. You need some form of imaging, some radiology to detect it. So whether it's a form of initial period diagnosis of prostate cancer, or whether you want to stage the disease, whether you got early disease or advanced disease, and what sort of treatment that is suitable. And when you've had your treatment, like in this case, robotic surgery, if the PSA goes up, what do you do? So we need some form of imaging to cover all these areas. And please interrupt me if you find that the topic is too boring in the way you're presenting it, but it's difficult to present it in a way that this is one of the topics. Either you make it too simple or you make it too difficult. To find a middle way is quite difficult. So we're going to talk about three new things. I think you may have heard of MRI ultrasound fusion for biopsy, and then we talk about multi-parametric MRI, and then PSMA PET. These are three very, very new things which are being discussed and being investigated worldwide. So before I proceed, I must remind you that I'm not a radiologist, so my knowledge on certain things are not up to the level of a radiologist. We have been introduced to MRI ultrasound fusions. There are software available to how to do this. There are companies which have approached us. I'm sure they've also approached University Malaya and HKL, other places, but I don't think any of us has actually embarked on this yet. Again, we are not radiologists to read MRI. MRI is very difficult for a clinician to read. For a CT scan, I think we are quite okay to look at CT scans, but for MRI, you require a lot of expertise. So this knowledge is keep on going, changing, and there's a lot of research, and I suppose what they say today may be changed tomorrow and the next day. So when we talk about diagnosis of prostate cancer, you all know that about raised PSA, prostatic specific antigen blood test. You do a normal digital rectal examination, you feel a nodule. So either one of these points to the fact there may be prostate cancer. So then you need to do an ultrasound guided biopsy of the prostate. So you need to do the third one as well. So you've seen this, some of you have gone through this. You can't put a picture, but I just put this diagram, how is it done. You transrectally, you take some biopsy of the prostate. So this is routinely done. You go and see most urologists will do it in the setup, whether in the hospital or in their clinics. And from there we get some tissues. And how do we do it? Well, this is a standard approach. If you look at number C, that's what we do. We do the standard template, which is 12-core biopsy on either side of the prostate. So to get the tissues. Okay, and then of course there are certain modifications that came along with it, using Doppler ultrasound. That's to show there's increased flow in the area where we suspect a tumor, because some of the tumors are not seen. So-called, you can't see anything. In prostate, sometimes you see a lesion, so-called a clear or hypoechoic lesion, but it may look the same like the other parts of the process. So there was talk about doing pulse Doppler, color Doppler to help enhance the detection. So the issue about transrectal ultrasound is that detection rate is somewhere about 40 to 45% using the 12-core biopsy. So we want to increase the rate. How do you increase the rate pickup and picking up clinically significant tumors and not picking up insignificant tumors. And what about areas, maybe in the anterior apical areas where it's difficult to get the biopsies? So these are issues that we are grappling. You go to meetings, people are discussing all these things. So we come to this MRI fusion. This is one of the equipments that are available. You have the template for the biopsy on site. You can do it transrectally or transperineally. And then you have the software and you have the ultrasound machine all incorporated. Of course, the MRI has to be done first before it is set up with this. So what are the indications for MRI-guided biopsies? So basically, it is for repeat biopsy. At the moment in time, it is for repeat biopsies where there's clinical suspicion of prostate cancer despite negative standard ultrasound biopsies. So sometimes you may also want to look at certain areas which are not accessible. Based on the ultrasound, you can't see any lesions there, but you want to confirm with MRI. And it's also used for follow-up on patients with localized prostate cancer who will be treated with active surveillance. So you survey a patient with active surveillance, MRI probably is a method to assess to see whether the lesion has there been any change to it. So this is the diagram to show how we schematically divide the prostate. And EAU is the European Association of Urology. It's the standard we use for Malaysia. Most of us, I think all of urologists in Malaysia use the guidelines for the European Association of Urology. And basically the recommendation is that before you do a repeat biopsy, perform multiparametric MRI where there's a clinical suspicion of prostate cancer in spite of negative biopsy. So it's quite a high recommendation. And when you do a repeat biopsy, don't just target the area, but do other areas as well. Do biopsies from other areas of the prostate. So that's the recommendation. So how do we do fusion biopsy? Two ways. One, in-core MRI-guided fusion. The other one is cognitive MRI fusion, and the third one is device-mediated MR ultrasound fusion. Okay, so 3 ways of doing it. In BO as well, they're doing an MRI, you do the biopsy. I think this is too difficult to do. It's basically very difficult to do. The other one is cognitive. So the urologist who are doing it saw the MRI, so look at the lesion on the MRI, oh, it's here, and then when he does the ultrasound, he remembers mental image of where it is, and he takes a biopsy there. So that one, you don't need extra equipment, you don't need to pay for any additional things. But it's not so easy to do. So what is being done basically now is basically device-mediated fusion, where the MRI is read by a radiologist. He'll show you the area where he thinks the lesion is, and then the thing, through some software, it can be superimposed when the radiologist does the ultrasound so that you can see where the thing is. So there are a number of multiple commercial preparations that are available. I mean, the software that you can use to do this. So okay, so you combine the two, you get fuse, you get an image to show. And this is just superimposition. You can see the top part. Top part is this is MRI, and the top part is the ultrasound image. You can see one red dot there. So superimpose, you can more or less use it as a way to make the diagnosis. And the challenges, of course, is that you need very good MRI, reading by the radiologist, and to be able to know how to read it. And of course, it's very new. Most of the radiologists in Malaysia actually do not do a lot of MRI per se. Of course, uroradiology as a subspecialty, something that's coming up. But they need to be able to pick up it well, and of course, you need to pay for this software to do this thing. The cost is quite a bit. In Malaysia, I think we've been told it's about in the vicinity of 400,000. That was a proposal for one of the companies. So I think something that we would like to do, but we have to see in time how to get it incorporated. Okay, so that's first time on MRI, ultrasound MRI fusion. Second part of my talk is on MRI per se, or magnetic resonance imaging of the prostate. MRI actually has been around for a long time. You probably, most of you, some of you are aware of MRI, some more aware of CT scans, but it's been used from the prostate since the 1980s. Initially, it is based on the images, T1 or T2 weighted images, and based on this, we were used to decide whether there's something in the prostate that can, be said to have a prostate tumor there. And the role initially was mainly for staging of patients with biopsy-proven cancer of prostate, which we still do nowadays. So we do a transrectal ultrasound. You think patient can go for surgery, so we do an MRI to see where it is in relation and whether it's localized to the prostate organ confined tumor or whether it's spread outside the prostate. Is this okay, or is it too detailed? Please let me know. I think
Great to know.
if it's too detailed, then maybe we skip the technical part. So now we talk multiparametric. It's not just images. The one I described was anatomical, just images T1, T2. Then we combine with what we call dynamic or physiological assessment, which is diffusion weighted imaging and dynamic contrast enhanced imaging, MRI. So these two things combine and you get what is called multiparametric MRI. So the idea of doing this is so that we will improve the detection of clinically significant prostate cancer, thus reducing the mortality in these patients who have significant prostate cancer. And that they can diagnose in confidence that you can exclude what are the things that are not life-threatening, such as benign conditions, and also you can avoid unnecessary biopsies of insignificant cancers. Okay, so T1, T2 has some characteristics. I don't think I actually want to go through it, how the images look like, but T1 is basically to see where there's the area of hemorrhage in the prostate, delineate the outline of the prostate, and T2 is to delineate the actual anatomy and whereabouts in the prostate you see the lesion. So sorry, I don't think these are very clear, but these are just to show you how the thing is applied. I don't think I'll go in detail. T2 is just to look at a lesion. Images may appear as usually hypoechoic or defined lesions, hypointense lesion within the prostate gland. And then diffusion weighted images. This is reflect the random motion of water molecules as a key component of prostate NP MRI examination. So I'm reading to you things that I actually don't do in routine practice. This is as much knowledge to you as me, because it's not something I do every day. So there's ways to pick up based on these images. Right? And then dynamic contrast, when we actually give some contrast. The contrast that we do is low molecular weight gadolinium. This is a contrast medium which is used, and it helps to define the area where the tumor is early. Enhancement as compared to the other area of the prostate. So you can see some of the images. I hope it's the lower area that appear very wide there with the arrow there. This is the area where the thing is. So the MP-MRI has been expanded. Okay, you have, as I said before, not just for staging, but to assessment of characterize where the lesion is, suspected recurrence, to help us with biopsy, for surgery, for focal therapy, radiation, etc. So based on that, this is again the European guidelines. Where do we do MRI in the patients? Do we do it for everybody? So the recommendation is that you should do it for intermediate risk prostate cancer, those with at least a cleaved distant fold pattern, and you should do it definitely for high risk prostate cancer, where usually some form of active intervention is being recommended to the patient. So we come to the next one, which is more confusing. This is called PRADS. This is another thing that is called prostate imaging reporting data system. It's PIRADS. It's a way of stratifying. This was devised by the European Society of Urogenital Radiology, and it has a version 1, which came out in 2012, and recently we have version 2. And it is a way to stratifying how the findings on MRI. So it is a way, it's like this is the standard of reporting that you should have for radiologists. And it relates only to MRIs alone. As a way you detect or you standardize, and you based on your imaging, you see an MRI, you decide whether this is acceptable, this is cancer or not cancer, what is the risk of being cancer. And also when you standardize, they reduce the risk of the variability in reporting, so that certain radiologists may report in a different way, the other one may report in a different way. So we have to speak the same language. But it's not, there are courses for this. Radiologists have to go for training for this, and they have to do it like consistently to be able to pick up and do it well. So the PIRADS 2, there are some recommendations. Of course, you do like this multi-parametric MRI, you have the T1, T2, you have diffusion weighted imaging as well as contrast enhanced imaging, but no spectroscopy. You can wait up to 6 weeks, but if you need to do an urgent biopsy, you can do it quickly. There's no problem with that. The machine should be at least 1.5 Tesla. Most of the machines in Malaysia, I think, are fairly new. It's 1.5. There are some higher end 3 Tesla machines. You don't need an endorectal cord because the machine is fairly new. You do not need it to do the study. So this is how this is divided. I think to avoid any eyes to look at it, is just to have some idea that when we're talking about PIRADS 4 and 5, this is the area where there's likelihood of cancer being present, and anything lower than that is probably may not be cancer. All right. So this is how the application, based on their scoring, you can decide whether there's likelihood of cancer being present. So okay, just to reiterate the key points, it is PIRADS is for MRI examination, and when it's 2, it is meant mainly in the initial stage. Before you decide whatever treatment, you do a PIRADS, you do an MRI, and you do a PIRADS score. You don't have to delay a biopsy to do an MRI, and you don't have to delay the MRI after a biopsy, and typically a 4 or 5 means a biopsy should be considered. Okay, so that's just a take-home message. So, what are the challenges? Of course, a lot of challenges, not just in Malaysia but elsewhere. You need you need wide availability of MRI machine. Most of the university hospitals and government hospitals, private hospitals have MRI machine, but of course they are also used for other things. So you need time to do these procedures, and you need a dedicated radiologist who will develop an expertise to do this, and with a corresponding software to do the thing. And so these are the challenges that we have to face. So this is just to humor you. There's some more other things that I won't talk about. Half the thing I also don't know what it's all about, but just to show you that this is changing. There's a lot of things going on with MRI, so in the future, I don't know, maybe it's possible to diagnose prostate cancer by MRI without doing biopsy, but it's something that may come in the future. Alright, so don't forget this radionuclide scan. I think some of you have had prostate cancer, you had advanced cancer, you have involvement in the bone. Still very relevant. Don't forget, we still do this. It's part of our staging, even in for localized disease as well as in metastatic prostate cancer. Okay, the last area I've just talked about briefly is the PET scan in CT in prostate cancer. It was actually for staging, for lymph node staging, and also for distant metastasis, also to look for biochemical recurrence, post-radical therapy. Now the problem with the things that are being used for PET scan, they are not so good for prostate cancer. That's the problem. So you had FDG glucose, it's a glucose-based thing, but the prostate cancer cells doesn't take up glucose so well, so it's not so good for that. And then you got the sodium fluoride, and then you got the choline. But these are all, choline is probably the best of the lot, but they are not as good as what we want them to be. So because of that, then he came up with this is PSMA, or prostate specific membrane antigen, which is a cell surface target, highly expressed in all prostate cancers. So this is found to be very ideal as a biological agent for PET imaging of the prostate cancer. So this is now the in thing, PSMA PET. So you can visualize lymph nodes, you can bone, the liver, elsewhere, visceral metastasis as well as the prostate. So it is the ability to identify and localize prostate cancer recurrence in patients with elevated PSA, but with no other symptoms after definitive therapy. So that is the goal. Your PSA is high, you got no symptoms, and you can't find where the thing is, then PSMA PET might help to identify where the recurrence is. So it's a gallium GA68 label P prostate specific membrane antigen. And I think Putrajaya Hospital has started doing it. I'm not sure in this team, but you know. So Putrajaya Hospital is doing some PSMA PET. All right, and current evidence is 92% accuracy in for high risk prostate cancer, and it also may help if there is, you can see a focus in the prostate. If you had negative biopsies before, it may help to point to the area where the biopsy should be repeated, and you can use it in combination with the multiparametric MRI as well. So it is complementary as well. So one of these area where it is looked at is for detection of lymph node metastasis. When we do radical prostatectomy now, more and more people are doing extended lymph node dissection. So this is an area where it has been shown to be useful as well. Okay, so you can see the graph there, the hotspot there. The smaller thing is the lymph node, where you can see this is the area where you can pick the lymph node. There's a prostate cancer, and the other side you can pick the lymph node. So it has its usefulness in this respect. So in summary, I hope you're still awake. Okay, we come to the end. So a lot of new modalities have come into place. I'm sure there will be, maybe in 5 years' time, Dato Selva get a radiologist to talk. Maybe he will talk to you something which is probably a little bit more different, because there's a lot of things that are going on. And what the important thing is, all these things should help us in making good clinical decisions. I think you have more tools, you can make decisions, you can individualize treatments for patients and management, especially in the area where there is follow-up for recurrence of disease. What do we do, biochemical recurrence, and things like that. So this open up a lot of avenues for management of prostate cancer. Okay, thank you.